This is the first lecture of the series for Next Level Hands-On course. And the title of the lecture is Theory to Practice, and this is basically the idea of the course. I was in academia for 25, 30 years, and then 10 years ago went into private practice, and very, very quickly it became apparent to me that there's absolutely no connection between academia and private practice. So about 7 years ago I decided to try to do something about that and to try to combine what we know to be good in academia, which is primarily the biological basis of endodontics, what is biologically required for a successful endodontic treatment, and then combine that with private practice where we'd like to make it efficient, streamlined if you will, and of course ultimately profitable. So this is the idea of Next Level Endodontics and the philosophy basically of the Next Level Endodontic teaching campus, if you will, both theoretical on Dentaltown and practical all over the world, is to use the theory as our basis and the clinical aspect as our the technology to make the theory work efficiently. So we started this setup where patients come to the office. Here is a picture of me in the office next door, and students watching us treat patients live, which is an extremely important part of this course, I feel, because asepsis and how we pass the instruments, etc., is a very underutilized and underemphasized part of successful treatment. We've now expanded. We have a treatments teaching facility in Munich, Germany. Here is Oslo, Norway. In Switzerland, in the FKG company premises, and now we've expanded recently to Mexico City and Dubai. So it's hopeful, or we hope that this will expand even more, and we'll be able to use our online campus as a springboard, if you will, for hands-on courses throughout the world. Now, as I said before, there's a tremendous difference of focus between the university and private practice. And these next few slides will illustrate this point. Here you have a slide of the biological outcome. Now, when I mean biological outcome, we mean the patient has no pain and there is no signs radiographically of periradicular disease. In other words, no lucencies which are of endodontic origin. And these studies are all done in universities. So in universities, you've got the faculty who, according to law, if you will, are not very good at doing it themselves. You know the saying, those who can do, those who cannot teach. So apparently we've got people here who cannot do it very well, and they are teaching undergraduate students who've never done it. So it doesn't look very good for the outcomes of these root canal treatments. But actually, when you look at the outcomes, and this is a tooth or teeth, a group of teeth, probably thousands of teeth if you take all the studies into consideration, where there's no radiolucency. So primarily vital teeth without microbes in the root canal system before the root canals were started. And if you look at the outcome, it's amazingly good. So 4 years later, 5 years later, no signs clinically or radiographically of periradicular disease in 89 to 96% of the cases. So a tremendously positive outcome for teeth with no radiolucency. When you look at the teeth with radiolucencies, and this implies again thousands of teeth where the root canal system is infected before the root canal is started, and here quite logically and quite easily to explain the success rate goes down maybe 10, 15, 20%, but still very, very high. So in a university environment, which is not the most conducive to excellent treatment, all of you have been in dental schools and they're not the most efficient places. So, you know, in this environment, you're still able to get extremely, extremely good success from your root canal treatments. Now, all the people now going to private practice, and these apparently are the hotshot clinicians. They would never stay at the university. They're much too good for that. And surprisingly and extremely depressingly, if you will, the success rate in private practice, as you would really logically expect to go up, goes down maybe 40%. If you average out all these studies from cross-sectional studies, the success rate is probably 50%. Some are 40%, some are 60%, but on average it's 50%. And remember, beforehand it was 90%, 95%. Of course, we don't know which started vital, which started non-vital, but still a 50% success rate is absolutely unacceptable. So something is going wrong between what people learn in the university, or actually don't learn in the university, and then they come into private practice and they're obviously dropping the ball in terms of biological aspects of endodontic treatment. And I, having been both in academia and in private practice, I have a very strong feeling about what happens. I mean, in dental schools, we teach students based on fear, if you will. If you don't put on a rubber dam, you don't get a signature. If you don't get a signature, you won't pass endodontics, and if you don't pass endodontics, you won't become a dentist. So the endodontic procedure becomes a signature for rubber dam, a signature for access cavity, a signature for instrumentation, etc., 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 but no real appreciation for why you put on a rubber dam, why your access cavity has to be such and such, such and such. Then this person goes out into private practice, and the senior in the private practice puts his or her arm around the now dentist and says, okay, let's forget everything you learned in the dental school. You don't have to worry about all this nonsense, rubber dam, this and that. You know, you took 3 visits for a root canal. Now I'll teach you to do it in not only 1 visit, but I'll teach you to do it in 20 minutes, etc. And because the student doesn't have this really strong biologic basis in their minds, they will easily accept this new real-world philosophy, which is actually a very poor philosophy, because the periapical tissues, which heal or don't heal based on the number of microbes left in the root canal, they are not impressed if you've done this root canal in 1 hour, 2 hours, or 20 minutes. The periapical tissues will heal under certain circumstances and will not heal or actually produce apical periodontitis, periradicular periodontitis under other circumstances. So again, we are trying to combine these two. Now, another point to make very, very clear, and this point has become stressed and more important recently, since endodontics has to justify itself, or has had to justify itself compared to implants, or as opposed to a treatment protocol where a dentist might choose an implant. So we have, for the last 50, 100 years, concentrated mainly on academic success, if you will. No detectable disease, perfection. Patient feels nothing. There's no signs of apical periodontitis on the x-ray. There's another very important aspect of success, and that's functionality. In other words, survivability of the tooth in the mouth. Now, when I showed you the success rates, both in private practice and in academia, we have to understand that all those teeth were in the mouth in order to be evaluated for success or not. But since implants, we've become very, very aware of functionality. And it is also possible, and very likely, if you will, that a tooth with a failure in terms of academic success can function very, very well for the rest of the patient's life. Symptoms in apical periodontitis and pulpitis, if you will, are an exception rather than a rule. Only about 30% of the teeth with pulpitis and 30% of the teeth with apical periodontitis actually show signs and symptoms. So it is possible for a tooth to function very, very well even in the presence of apical periodontitis. But on the other hand, and very importantly, you can have a tooth which is very successful from an academic point of view that can be lost to function by fracture, by other factors other than endodontic treatment. And this has become very, very important, because what we've found in recent years is that the way we treat our root canals with NiTi files and the new technologies may actually make the teeth more susceptible to loss in functionality while being more successful in terms of the presence or absence of apical periodontitis. So we have to take both of those into account. Now, the question that we have is, do the new technologies allow us or grant us a better success, number one? And number two is, if we combine the biological aspects that is so strong in academic environments with the new technologies and the more sophisticated clinical procedures that we are seeing now in the last 5-10 years with new technological advances, microscope, very, very sophisticated instruments. If we can combine these two, can we equal or actually better the success of the universities in private practice? And this is a picture of a very close colleague, Gilberto Debellion. He was at the University of Pennsylvania and trained under the same mentor as I. I was Leif Tronstadt's first student at Penn, and 10 years later he was in Tronstadt's last class at Penn. So we have the same training. Gilberto then followed Tronstadt to Norway to finish his PhD, and he stayed in Norway and has lived there for the last 15, 20 years. I'm not sure exactly how long. So we decided to do a study where he would follow 120 consecutive cases in his private practice. And the significance of this being done in Norway is that in Norway you are able to get follow-ups. If we do the same study in my practice in the United States, generally we would get 20% follow-up, even less than 20% follow-up. In Scandinavia, for reasons I don't really understand, but probably because the society is much more stable and people live in the same place for longer periods of time, generally you get over 80% follow-ups even for 4 and 5 years. So this is a very easy study to do. Nothing's easy, but in terms of follow-up, it's an easy study to do in his office. So this is a relatively easy study to do in his office. So what we did was took 120 consecutive cases, and it just so happened, as is the case in most endodontic offices, that there were roughly equal vital and non-vital cases, so about 60 of each, and then they were followed up for 4 years. And what you see, and this is with a PAI evaluation system, which generally gives you a lower success rate than a purely subjective, where you say, was it better in the follow-up x-ray compared to the pre-op x-ray, which is very biased when you've done the cases. So a PAI system is more digitized. You can look it up if you're really interested, and generally gives you a lower success rate than subjective. Now, if you look at the vital teeth after 4 years, you will notice that, and not surprisingly to me, knowing DeBellion and knowing his biological background, he was able to get 94.6% success in his vital teeth, very comparable to university-based studies. But when you look at the non-vital infected teeth, and remember, in the non-vital infected teeth, even in the university-based studies, the success rate went down to high 70s, low 80% in the university-based studies. And what's very, very exciting in this data is, at a 4-year follow-up, using the PAI score, he was able to get over 90%, 91.3% success for his non-vital teeth with apical periodontitis, which is extremely high and proves to me and him, and I think to everyone, that if you use a biological approach, which is so strong in the universities, and use the modern technologies to achieve the biological aims of endodontic treatment, you are able to be as successful, and actually even more successful, than the university-based studies in your outcome, and we should be able to achieve these success rates. So what I'm trying to say, or claiming, that anyone who goes through this seminar and our hands-on program, etc., if you're able to choose the correct cases, and you choose cases where you can achieve the biological aims, and that's a skill in knowing which cases you can do and which cases you can't do. But if you choose a case where you are able to achieve the biological aims, and you do that and do what is necessary using the new technologies, then you should get more than 90% success, both for your vital teeth and your necrotic teeth. So we are going to, for the rest of this course really, we're going to go over and stress what we believe are the biological principles required for successful endodontic treatment, and then suggest technologies which will enable you easily and predictably to achieve those biological aims. So I'm going to give you some examples here of vital teeth that DeBellion treated, and of course I've got access to all 120 cases, so I'm picking cases that fit the lecture, if you will, and fit our philosophy. And also we'll look at necrotic cases. And what you'll see and notice is there are many differences from what is generally taught in clinical endodontics today, and generally pushed by industry as the way to successfully, quickly, efficiently do root canal treatment, which in my mind very easily shows why the success rate is not as good as it should be. So the first point I want to make, which is a very important point, is that our biological success in endodontics, the success of no radiolucency periradicularly and the patient feeling asymptomatic, if you will, that success is achieved in the apical 3 to 4 millimeters of the root canal. That's where the obligate anaerobes are, that's where the complex anatomy is, and that's where, to a great extent, the microbes in the root canal are communicating with the periradicular tissues and are causing an inflammatory response in the periradicular tissues. So how well we control those microbes, how well we block that area, is going to determine what our success rate will be in the root canal. So now, of course, we cannot determine how well we clean, so we have an indirect determination, and that is what our obturation or our root filling looks like. So what we are looking for in the radiographic picture of our root canal filling is a dense, relatively thick, last 3 to 4 millimeters of the obturation material. The second point that we stress that is probably different from the norm is that your functional success, this is that the tooth doesn't fracture, that you can restore the tooth, that it's there solid in the mouth for as long as the patient is alive, depends on the coronal 2/3 of the root. And the coronal 2/3 of the root, from a microbiological point of view, is relatively easy to take care of. In fact, I would claim that you don't need any special talent or any special instrument in order to clean or control the microbes in the coronal 2/3. So with that said, every bit of dentin that we remove from the coronal 2/3 is really unnecessary dentin and will jeopardize the long-term functionality of that tooth. So what we want to do in the coronal 2/3 is touch the walls, keep everything clean if you will, but don't over-prepare the coronal 2/3. And this is completely different from the norm today. As probably most of you understand, if you go to any website or you look at any advertisement for a new file, etc., what you see are these huge tapers, which is actually removing unnecessary dentin from the coronal 2/3, and then the root canal comes to a very fine point and the apical 3 to 4 millimeters, which is exactly what we don't want to see. So basically what we're looking for from a biological point of view is a thicker, more dense apical 3 to 4 millimeters, and then a much more parallel, not completely parallel because we want the natural shape of the root canal obviously, which is conical shape, but much more parallel in the coronal 2/3. And then the third point, which is amazing that has ever gone out of this point, if you will, or out of this norm, is that for the best success in root canal treatment, you need to stay short of the radiographic apex. And most philosophies today, reasons I just absolutely cannot understand, will tell you that you need to go close to the radiographic apex. So if you have to be short of the radiographic apex, where are you filling to? You know, you can read in the literature minor foramen, major foramen, apical constriction, etc. But from a biological point of view, it's very simple. You're finishing to the cemento-dentinal junction. Where the dentin ends, the pulp ends because the pulp forms the dentin. Where the cementum starts is the start of the periodontal ligament. And the periodontal ligament doesn't need our help in healing periodontal inflammation because that's outside the root canal. So from a very, very simplistic point of view, we have to fill to the cemento-dentinal junction. And the cemento-dentinal junction is short of the radiographic apex because we have a cemental cap over the tip of the root formed by periodontal ligament. So filling to the cemento-dentinal junction, will always be short of the radiographic apex. And actually this jives with our apex locator literature. Unfortunately, we don't have apex locator literature which correlates your reading of your apex locator with outcome. All our outcome studies are radiographic, and they all point to the fact that you will get a better success rate if you fall short of the radiographic apex. And in the case of vital teeth, which we're showing here, it should be about 1 to 2 millimeters short of the radiographic apex. So to look at this case again, we want a well-filled 3 to 4 millimeter area. We want minimal taper. I would say I never go larger than an 0.4 taper when I've got my apical part to the size that I need, and short of the radiographic apex. Now, as I said, I have access to all 120 cases, so I'm picking a case here which is right on the edge. And I must admit, as an endodontist, if I took my check x-ray and I was this short, I'd sort of feel a little uncomfortable. But being a biological endodontist, I know that this is quite acceptable. So this is 2 millimeters short, which is within the acceptable range. And is it a good root canal? Yes, it is a good root canal, because my definition of a good root canal is a root canal that after 4 years shows no periradicular inflammation and the patient is asymptomatic and happy. So this is a good root canal and quite acceptable in a vital case. Now we have an example of a necrotic case with apical periodontitis. So the canal system is infected, and we have controlled the infection to the extent that the patient's asymptomatic, and the radiograph shows healing, as you can see, as a comparison to the pre-op and then the 4-year follow-up. Now you'll notice again, well filled in the apical 3 to 4 millimeters, minimal taper. Now I'm not saying that if we turn that tooth around in the buccolingual dimension that we are not going to see a wide open root canal, but that's taken care of not in a round way to decrease the thickness of the tooth, but only in the direction of the thickness of the root canal. And we're going to show you technologies which allow you to do that. And then you'll also notice, and I want to point out, that the root canal fills closer to the radiographic apex. Now, if we had a room full of people that we're lecturing to, I would usually ask, why do we go closer to the radiographic apex when we have a non-vital tooth than a vital tooth? And 99 times out of 100, the answer is because you've got microbes and you have to get closer to the radiographic apex to get rid of those microbes. And that's not true at all. I mean, you do want to get rid of all the microbes, but basically you're still going to the cemento-dentinal junction, because that's the area of the root canal where it's not possible to get rid of all the microbes. The reason why in a necrotic tooth the case is closer to the radiographic apex is that in a necrotic tooth we have apical periodontitis, and with apical periodontitis we have resorption of the apex. And when you have resorption of the cementum of the apex, that appears to be closer to the radiographic tip of the root. So that is the reason why you need to get closer in a vital tooth. And as we know from our in a non-vital tooth, I'm sorry. And as we know from our outcome studies, the best outcome is 0.5 to 1 millimeter as opposed to the vital tooth, which is 1 to 2 millimeters. Here it's 0.5 to 1 millimeter in a tooth with apical periodontitis. So not because we're going to a different place, we're still going to the cemento-dentinal junction, but because there's resorption at the apex. And here you have a histologic picture to demonstrate the point that I've just made. On your left-hand side is a vital tooth, and you can see an intact cemental cap. This is the cemento-dentinal junction. So if we aim for the cemento-dentinal junction, this is going to be 1 to 2 millimeters short of the radiographic apex. We can actually be another millimeter short, and in the absence of microbes, blood will will flow in, and the apex will reform. So this is a very forgiving situation with a vital tooth. With a tooth with apical periodontitis, we have, as you can see, resorption of the apex. The cementum is removed, which causes problems with the microbes, which I'll explain in a minute. But you can imagine an x-ray from this aspect. Here we're filling again to the same cemento-dentinal junction, but the radiograph is going to appear to be much closer to that point. So filling to the same point, vital or non-vital, this one is going to look 0.5 millimeter short, and this one will look 1 to 2 millimeters short. And in this slide, my whole point is made, if you will. This is a review article about the difference in success rates of vital versus, of short versus long. And what you can see in every single one of these cases, short gives you a better success than long. So, I mean, there is actually no doubt that this is the way to go in terms of a better success rate. Now, I want to make a point. I'm not talking about sealer through the apex. I'm talking about the main point through the apex. And this is very important because, you know, the impression you'd get in working in an extracted tooth is that you could push long and then pull the tooth very, very tight on the other side, and you'd get the best seal at the apex. But when you're dealing with a patient in an in vivo situation, of course, this is not the situation. You push the main point through the apex, and there's soft tissue, bone, it's a periodontal ligament on the other side, and this pushes back. So actually it's impossible to seat a gutta-percha cone adequately if you push it through the apex. You always get this reaction of pushback, and that results in an overextended but an underfilled root canal cavity. The analogy I would use is if you fill a normal MOD cavity with a matrix band without wedges in there, you can push and push and push and push. The material goes into the periodontal ligament, but the cavity is never really properly filled. As soon as you put a wedge, excuse me, put a wedge into the mesial and the distal aspect, now there's nowhere for the material to go, so you push down and everything works laterally or moves laterally, and now you can get a well-filled cavity. So this is the same analogy. So actually when we fill a root canal, we need a seat for the gutta-percha, and that seat is created by instrumenting the root canal slightly larger than the minimal diameter of that root canal, so you get a little shelf which the gutta-percha can seat on, and that moves the sealer laterally and stops the gutta-percha from going through the apex of the tooth. And here is a vital tooth, and not the same tooth obviously, because we don't extract successful root canals, but this is from a study, and what you can see here is that even if you fill short in the absence of bacteria, and the absence of bacteria is much easier in a vital case, of course, then the root canal will reform, tissue will come in. Doesn't have to be pulp tissue, in fact. In fact, in this case, you can see cementum. So the periodontal ligament tissue came in there, and you have the best filling of the apical millimeter or so that you possibly could have. That's vital, non-infected tissue. So you've got a complex anatomy here, and this is filled with tissue that is vital, that's not infected, and that can defend itself. And actually, even if you fill or instrument long, you should fill short. And again, from the same idea here is I've instrumented long, hopefully inadvertently. We don't want to instrument long purposefully. You instrument long, you fill short, the blood will come in, and in the absence of bacteria, that apex will reform. So from a clinical perspective, if you take a check x-ray and you're long, you go back, you fill short. And you fill short, we've got many tricks you can use. You could go instrument a little bit larger to create that shelf, cut the gutta percha, etc. We'll get into that later in the course. But generally, we should always fill short, even if you've instrumented long. Okay, so now basically I hope that I've made the point that we can get a very good success rate in private practice, and also the three main issues that we stress bringing the biology to the root canal, to private practice, I'm sorry. And now we're going to get more specifically into the biological aspect. So the first thing that we stress in our philosophy is the difference between the vital tooth and the non-vital tooth, which is the infected tooth. And that's the key, is from a clinical perspective, a vital tooth is not infected. So from a biological point of view, if our disease is apical periodontitis, a vital tooth cannot have our disease present, if you will, because there's no infection in the root canal. The non-vital tooth, on the other hand, is a tooth where in 99% of the time the infection is already there, or in a few cases, like traumatic injury cases, infection is inevitable. So a non-vital tooth is a major challenge in root canal therapy because we have to control the microbes that are already there. In the vital tooth, we have to control the microbes getting into the root canal if we're going to do root canal therapy. So when we look at a lesion like this, and obviously we've picked a slide where there's no doubt in anyone's mind that there is a large lesion there of endodontic origin, periapical radiolucency, if you will. And we should all know and all appreciate that in these cases, in order to have a lesion of this size, you need a heavy infection within the root canal. And if you have a heavy infection in the root canal, that pulp is necrotic. So to put it all together, in order to have apical or periradicular periodontitis, which is our disease in endodontics, you need an infected